Good afternoon to all. My name is Isabel Cuervo-Suarez. I'm a family doctor from Colombia with a master's degree of pediatric palliative care. I work as a physician in Fundacion Valle de Lili Hospital. Today I'm going to present to you the study that we carry out named Pediatric Palliative Care During End of Life, a privilege of a few in a tertiary referral hospital from Colombia. The background, according to the WHO, this is the distribution of people in need of palliative care at the end of life by age group. Almost 20 million people needed palliative care at the end of their life, and 6% of children needed. Of these children, 97 are from countries that are low and middle income countries. Colombia, where I'm from, is an upper middle income country. This is Colombia, is located in South America, and Global Atlas of Palliative Care classified Colombia as a poor provision of palliative care. In Colombia, we have isolated provision of palliative care, and pediatric palliative care relies on private institutions.
Sí.
That is because pediatricians treating patients with life-threatening disease do not exist as assistants from palliative care team, probably because lack of knowledge about the file. This is Fundación Valle de Lili. The photograph is a tertiary care hospital located in Cali, and it serves as a referral center for pediatric patients with life-threatening disease. The hospital has 510 beds, of which 177 are for pediatric patients, and 71 correspond to pediatric intensive care units. The aim of the study is to describe the access to palliative care in hospitalized children during end-of-life care in a tertiary hospital, and to compare the circumstances surrounding the death of hospitalized children that receive palliative care and those that did not. The methods, we perform a retrospective chart review of pediatric patients who died at Fundación Valle de Lili Hospital from January 2013 to December 2016, who were hospitalized, and we include children less than 17 years old who were hospitalized 72 hours before death. An initial screening of the digital clinical record system retrieved a total of 737 patients, and the study group was selected by randomly a sample of 100. We exclude 30 children because of trauma, suicides, and other diagnoses. We started the 72 hours before death, and we analyze the two groups, the children who receive palliative care and the children who do not receive palliative care because they were in charge of pediatric intensive care unit, surgical specialties, and oncology. The variables that we analyzed was the demographic information, clinical characteristics, hospital resource use, diagnosis, and in hospital outcomes. The outcome of interest was the proportion of pediatric patients that receive palliative care by a palliative care physician in the last 22 hours of life. The results were presented using frequency and percentage for dichotomous and categorical variables, medians and interquartiles range for continued variables, And we did a logistic regression was used to calculate propensity score to predict the provision of palliative care by a palliative care physician for covariates like gender, age group, type of enrollment to the Colombian health system, ACT categories and diagnosis, and use of antibiotics. This is the results, the general characteristic of the population. We have 87 children. Most of them were neonates, males, and the cause of death was because of congenital malformation, deformities, and chromosomal abnormalities. And most of them were in category 4, the ACT. This category means that the children has irreversible but non-progressive condition causing severe disability. Here we have the patient characteristics and outcomes after propensity score matching. We mentioned one-to-one pairs of patients who did not receive palliative care. We compared this group and with an N of 10 patients, and we can see that patients who do not receive palliative care die in the ICU with mechanical ventilation and receiving CPR. In contrast, the children who receive palliative care died receiving comfort measure and non-escalation of care. So, in this single center study to describe the access to palliative care in hospitalized children during end of life, we found very concerning findings. Only 10% of 87 patients were treated by pediatrician palliative care team and then of the life, which is equivalent only 11%. Pediatric palliative care is still poorly recognized and needs awareness from the healthcare professional to improve the quality of life and end-of-life experience of patients and families. In Colombia, there are no pediatric palliative care units currently. The information in this study is a call to action for developing intervention for delivering pediatric palliative care services and to increase the awareness about the file. There are two key priorities to respond to the crisis to the access to palliative care. One is to work with stakeholders like Minister of Health and Education to start a discussion about a formal training program in pediatric palliative care and to implement pediatric palliative care services. In our study, palliative care was consulted very late, near at the end of life, and pediatric palliative care should be provided shortly after diagnosis of a life-threatening disease. In our study, the children under the care of non-palliative care physician were more likely to die in pediatric intensive care unit with life-sustained therapy, and the patients who received palliative care were more likely to die in pediatric general ward with comfort measure and with non-escalation of care. Okay, it doesn't change. Okay. Finally, I want to share that we have the pediatric palliative care program in our hospital. It's named Taking Care of You. We treat children, their families, and their illness, always seeking to offer quality of life to our patients. This is my team from left to right, the psychologist, secretary, me, family physician, the nurse, the pediatrician, and the social worker. I want to thank this space that you gave to me. Thank you.
Well, thank you. That was very informative. In our country also, there are pediatric palliative care is much behind and far less than adult palliative care. And in fact, in the medical part, our boards have both peds and adults, with being more adult questions. There aren't separate boards yet.
We also have adult palliative care in our clinic, and our team started the program 3 years ago only. So before they were treated by adult palliative care physicians.
Mm-hmm. Yeah. Now, any questions from anyone else?
No, I just have a comment. This is Marquita Suttle. I am an intensivist in Columbus, Ohio. And I will say that our palliative care team, our pediatric palliative care team, is very well integrated into our ICU. The chief of palliative care in Columbus, really about when she arrived 8 to 10 years ago, I think she started from the concept of, I really need to be visible in the ICU and get to know these people, and then kind of progress into an education phase. And now we have a whole set of triggers where palliative care is automatically consulted. And we joke that she's basically an intensivist. Her and her team are intensivists at this point. So it definitely took all of 10 years to kind of achieve that goal. I certainly view us as, colleagues within the ICU. And I think that it was just a very long process and kind of a stepwise and very thought process on the behalf of palliative care.
Yes, we also now we have a very good relationship with the intensive care unit physicians, and it took 3 years. So now we are vetted, and we are doing a great job with them. As you said, we pass the round and see the patients with them, and we take decisions together.
Yeah, I think your point is well taken too. Like, I think sometimes myself and my colleagues probably just don't realize all of the other services and resources that the palliative care team can offer. I mean, it took a long time to make people understand it's not just for end of life, it's for sibling support, for family support, all of the other things that palliative care has to offer. But it certainly was a process, but it was a process that was well worth it. So good luck continuing that relationship.
Thank you. Thank you very much.
Well, and as Hunter Groninger pointed out in his study with COVID, it's actually the non-physical things that are being used for the palliative care.
Yes.
I think it's very interesting in our palliative care department, which we are serving approximately 55 children on any given day. That's our typical census. But most of them are palliative care, even though they are hospice appropriate. So I think it makes it easier for the family as far as our peds department goes. They just work as if, they're all one and the same, and they don't separate between a palliative care department and a hospice department for the peds. And many of our peds patients will die still being under palliative care, never having gone to hospice. So I think that's a helpful thing that we have found.
Good.
Well, the other thing is, in our country, which probably wouldn't be for any other countries because of the Medicare guidelines, with peds, you can have concurrent care. It's not like adults where you can't with Medicare. So that works out really well.